And you are going to invite or introduce. Who is going to introduce?
Sir, I'm going to introduce
All
you.
right,
I will
fair,
let sir also. Yeah.
fair enough.
Any slides are okay?
Yes, sir. All okay.
நம்ம பேக் சீட்ல ரெண்டு தண்ணி பாட்டிலையும் எடுத்து வைக்கணும்.
Shall we start?
Yeah, I think we start.
Okay, sir. Good evening, friends. I, Arun Chadha, Associate Vice President in Das Pharmaceutical, takes immense pleasure to welcome you all to this online knowledge platform. Today is the 17th episode of Secrets of Neurology. Today we will witnessing the case study of Tirunelveli Medical College. Since you all are knowing that this program has been designed by Honorable Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, and it's honor for me to give the brief about our program directors. So, first of all, Dr. Sudhir Shah sir, he is the professor and head of department NHL MMC and SVP IMSR Ahmedabad and director of neurosciences Sterling Hospital Ahmedabad. And further to this, our second course director is Dr. Lakshmi Narasimhan sir. He is a director and professor, Institute of Neurology, Madras Medical College, Chennai. So I welcome you all, sir. Nothing to take much of your time. I handed over this session to Dr. Sudhir Shah, sir. Over to you, sir.
Thank you. Thank you very much, Mr. Chadda, Dr. Haley, and the whole Intas Globusel team. I must, at the outset, congratulate and thank you for consistently supporting us logistically for this wonderful series of webinars. And as you know, today is the 17th episode of Secrets of Neurology, Knowledge Feast for all neurologists. So this program is now famous for number one, consistency. I don't recollect any such ongoing high caliber scientific program for one and all, specifically students and freshers, as well as uh, professors even. And the third important thing is the commitment with what the delegates are joining. So consistency of the program, high high caliber scientific content, and the third is the commitment of the neurologists to join this program. So I'm thankful to one and all, and I stand humbly in front of you all, thanking you again and again. And I also wish to take this opportunity to wish you all Happy New Year, because we are meeting after the New Year for the first time in this new year. I also want to congratulate and thank my close friend, Dr. Lakshmi Narasimhan, for his dedication and hard work in making this program so successful. I would like to invite today Tirunelveli Medical College, Tirunelveli Medical College from Andhra Pradesh. I want to thank them for accepting our invitation. And
Tamil Nadu, sir. Sir, from Tamil Nadu.
from Tamil Nadu, sorry, yeah. I'm sorry, I made a mistake. Tamil Nadu, somewhere near Madurai, right?
Near Kanyakumari, sir. It is near Kanyakumari, sir. The
Yeah,
southernmost part of Tamil Nadu. Sir.
Yeah, fine, wonderful. Thank you for correcting me. And I have Dr. S. Venkatesh, who is a resident, who will be presenting the case with history and the examination part. Dr. Jasmine Kalyani is the assistant professor who shall take this forward as for the investigation and discussion part. And I have my old friend, Dr. S. Saravanan, who is a professor and HOD. He will make expert comments and concluding remarks. I'm more happy to have you all here. And I wish to thank once again to all people who are part of this webinar, particularly today the team who is going to present from Tirunelveli. And I want to welcome Dr. S. Saravanan for his introductory remark, and then we will start program straightforward.
Sir, with your permission, I just wanted to thank Dr. Saravanan and his team for accepting on a very short notice, sir. And secondly, Dr. Saravanan is doing lot of work in stroke, especially in training grassroots people. He has trained more than about 20 village health nurses, entire village health block for regarding stroke identification and stroke care, and integrated them into the system, sir. He's doing quite a lot of work, and Tirunelveli Medical College is one of the apex center for stroke in ICMR. They have a very strong stroke base there, sir. Which I just wanted to thank Dr. Saravanan. Over to Dr. Saravanan. Thank you.
Thank you for those additional remarks, Dr. Lakshmi.
Thank you, sir. Thank you.
Thank you, sir. Thank you, Sudhir sir. Thank you, Lakshmi sir. Thank you very much for having given us this opportunity to present a case here. Today we are presenting a unique case which has got components of multiple parts of the nervous system, and which may be an exercise for a resident, and also a good eye opener for senior doctors also. So I request all of you to just watch and go through the case, and I request you all to give your expert comments also, so that we will improve our knowledge also. Thank you, sir. Our resident may present the case now.
Good evening, sir. Slides visible, sir?
Yes, sir.
Good evening, respected teachers and dear colleagues. Thank you for giving this opportunity. Today, I am presenting a case of a 13-year-old adolescent girl who is right-handed individual studying 7th class, a resident of Tirunelveli Valley, presented to the hospital with chief complaints of multiple ulcers over both legs for 1 month and numbness, paresthesias of right foot for 10 days, associated with difficulty in walking for 10 days. She also complaining of numbness, paresthesias of left little and ring finger, along with clawing of left medial 2 fingers for 1 week. She was apparently well 1 month back. Then she developed itching of both lower limbs and upper limb, along with reddish erythematous lesions, which gradually expanded in size and not associated with any lace-like pattern. A week later, these lesions converted to multiple painful ulcers. Mainly, pain is mainly during touching for both lower limbs, mainly on the dorsum of the foot and ankle. For the last 10 days, she has swelling up and pain of the left foot. She also gives history of vague discomfort in the back of right leg. There is no history of fever, myalgias, joint pains, Raynaud's phenomenon, blackening of toes or fingers. For these complaints, she consulted local physician, but there is no documents available. But she's taking tablet amoxiclav and cetirizine and soframycin ointment. After 2 weeks of onset of these skin lesions, she started having severe paresthesias, pins and needle sensations, burning, shooting pain, and associated with numbness of right lower limb over the sole, dorsum, and lateral part of the leg. She also has these complaints on the left hand, mainly in the little and ring finger, along with on the medial side also. These complaints are progressive, associated with cotton wool-like sensations on walking. And she also has difficulty in differentiating hot and cold sensation in these areas. There is no history of increased or decreased sweating, nail changes or hair loss. No history of wash basin phenomenon, lahermitocene, band-like sensation or girdle pain. After 3 days of onset of these sensory symptoms, she started having difficulty in walking, which is rapidly progressive, mainly of the right lower limb, in the form of unable to clear the foot from the ground, associated with the stamping of the right foot. She also unable to grip the chappal, associated with slippage of chappal, which she is unaware of, associated with frailness of the foot. There is no history of difficulty in getting up or no weakness of left lower limb. The weakness in the left upper limb is in the form of clawing of the medial 2 fingers with slippage of water through fingers while face washing. She also has difficulty in gripping, no history of difficulty in reaching higher shelf, no weakness of the right upper limb. She is able to sit from supine position and roll over bed without support. No history of myalgias, cramps, muscle wasting or twitching. No diurnal variation or of these weakness or fatigability or difficulty in releasing the hand grip. There is no history suggestive of cranial involvement or no history of tremulousness or incoordination and swaying while walking. No history of bowel and bladder symptoms. No history suggestive of extrapyramidal and autonomic nervous system involvement. No headache, vomitings, loss of consciousness, convulsions, abnormal behavior. There is no history of fever, photosensitivity, oral or genital ulcers, dry eyes, arthralgia, rhinitis, epistaxis, hemoptysis, jaundice, decreased urine output, breathing difficulty or abdominal pain. She is not giving any history of insect bite, recent vaccination or native treatment. Past history, she was diagnosed to have cervical lymphadenitis at the age of 5 years and proven to be tuberculosis by FNAC. Took 6 months of ATT and there was no other significant past medical or surgical history. There is no drug or allergy history. Except during these periods, she is taking amoxiclav and cetirizine. Personal history, sleep and appetite normal. There is no history of illicit drug abuse, no high risk behavior. Family history, no significant family histories. Summarizing the history, 13-year-old adolescent girl who is right-handed presented with past history of extrapulmonary tuberculosis at the age of 5 years. Presented with acute onset neurological illness in the form of rapidly progressive asymmetrical distal weakness of the right lower limb in the form of foot drop or flail foot, and left upper limb weakness in the form of ulnar clawing without proximal and other limb involvement, without fluctuation, atrophy or fasciculations with weakness. with sensory symptoms in the form of paresthesias, neuropathic pain, and numbness of the right foot and lateral aspect of the right leg, along with left medial two fingers and medial hand, without any involvement of cranial, cerebellar, autonomic nervous system, extrapyramidal, higher mental function involvement. Which these symptoms were preceded by multiple erythematous lesions and ulcers for the both lower limbs and upper limb, predominantly over the lower limbs, with cellulitis of the left foot without involvement of the other system. After summary, probable structures involved are from she has sensory symptoms in the form of positive symptoms like paresthesias and dysesthesias, mainly she has hyperalgesia and neuropathic pain. Negative symptoms in the form of numbness and decreased ability to differentiate temperature. So from history, we can, she has paresthesias and pins and needles and neuropathic pain. Neuropathic pain mainly occurs in case of involvement of small fiber involvement, and pins and needles, tingling and numbness occurs with the large fiber involvement. And coming to the distribution of these sensory symptoms from history. From history, she has decreased sensation and hyperalgesia for the left medial two fingers and the medial hand, along with the dorsum of the right foot and lateral leg, along with sole of the foot also is involved. So localizing these sensory symptoms, first we will go to the left upper limb. These sensory distribution should be differentiated from the root, lower trunk plexus, medial cord and ulnar. In case of C8, root, lower trunk and medial cord, normally they will involve medial two fingers along with medial side of the hand, and medial side of the forearm will also get involved. Whereas in case of ulnar nerve involvement, you won't get any medial forearm involvement. You will get only medial side of the hand, hypothenar side and lateral two fingers. So from this type of distribution, we can say it is ulnar nerve distribution. Next, coming to that right lower limb sensory symptoms, we should differentiate localize from L5 S1 root, lower lumbosacral plexus, sciatic nerve, or common peroneal plus posterior tibial nerve. In case of L5 S1 root and lower lumbosacral plexus, you will have sensory distribution in this pattern. And the medial aspect of that foot will get spared because it's supplied by the L4. And you will get posterior part of the thigh will also have sensory disturbances because of the S1. Whereas in sciatic nerve or common peroneal plus posterior tibial nerve, you will have throughout the all of the dorsum will be involved and all of the sole of the foot will get involved along with the lateral aspect. In our patient, we have this type of sensory distribution. So it can be either sciatic nerve or common peroneal plus posterior tibial nerve, because sole of the foot is supplied with posterior tibial nerve and dorsum of the foot is supplied with the common peroneal nerve. So it can occur either alone with sciatic nerve or with the common peroneal plus posterior tibial nerve involvement, combined involvement. Coming to the motor symptoms, it is the element pattern of involvement. In left ulnar claw hand is there. Mainly from history, I could able to make the weakness of the lumbricals because the patient has clawing because 3/4 lumbricals involvement, and she also has slipping of water from the hand through the fingers while face washing. So she had palmar interossei involvement. Localizing this claw hand along with these sensory symptoms from root, lower trunk plexus, medial cord, and ulnar nerve. Normally, in case of trunk and root involvement, other muscle groups like thumb involvement also happens. So, along with these sensory from history, we can make out only ulnar nerve involvement is there. In right lower limb flail foot, it should be differentiated from the L5 S1 root, lower lumbosacral plexus, sciatic or common peroneal plus posterior tibial nerve. In our patient, she doesn't have any proximal weakness, only distal weakness is there. In case of L5 S1 or lower lumbosacral plexus, the patient will have difficulty in walking, like waddling will be seen, or difficulty in getting up. Mainly actions or weakness of the hip will be seen. So our patient doesn't have, and the sensory distribution is also suggestive of sciatic or both combined common peroneal posterior tibial. So most probably from history, sciatic or combined CPN PTN involvement. So as our patient has one or two nerves in the right lower limb, or sciatic nerve or common peroneal plus posterior tibial nerve, and left ulnar nerve involvement. So two non-contiguous nerves involvement is there. So from history, we can put as clinical diagnosis of multiple mononeuropathy or mononeuritis multiplex with multiple ulcers and left foot cellulitis. Coming to pathology, from history, the symptoms has mainly neuropathic pain is there and paresthesias are there. Both small fibers and large fiber involvement is there. So unmyelinated plus myelinated fibers are both are involved. So it's from pathology, it's mainly going towards axonal than demyelination. Next, coming to the differential diagnosis of mononeuritis multiplex. And there is a vast list of differential diagnosis or etiology of mononeuritis multiplex. It can be infectious, infections, inflammatory, metabolic, hematological, paraneoplastic, toxic, hereditary. In infections, most common in India are leprosy, HIV, tuberculosis, and hepatitis A, B, C, HSV, or Paro B19. In inflammatory, vasculitis can be either primary, secondary, or non-systemic, and other connective tissue disorders. Metabolic, mostly diabetes, Hashimoto's, porphyria, amyloid. In hematological conditions, it can occur with hypereosinophilia, cryoglobulinemia, or ITP. In paraneoplastic, others, lymphomas, leukemias, or small cell lung carcinoma can also cause mononeuritis multiplex like presentation. Toxins, mainly amphetamine and gasoline. In hereditary conditions like Tangiers disease and HNPP can also present. Sometimes this mononeuritis-like presentation can also be seen with demyelination of multifocal motor and sensory neuropathy. The differential diagnosis of mononeuritis multiplex with the ulcers, it can be due to vasculitis, either primary, secondary, or non-systemic vasculitis, or connective tissue disorders, diseases like SLE, rheumatoid arthritis, Behçet's disease, infections like hepatitis B virus and HIV, and plasma cell dyscrasias and acute leukemias. Coming to general physical examination, she is conscious, alert, and on examination, multiple patches of pale center with surrounding hyperpigmentation over legs and arms are seen. Along with these, she also has left foot edema with tenderness and raised temperature. Along on the right foot dorsum, she also has active ulcer of 3 into 2 centimeters, which is discharging seropurulent discharge. Other ulcers are punched out edges with reddish base and surrounding induration and erythema is seen. There is no alopecia, rash, genital or volar ulcers, arthritis or subcutaneous nodules. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, thyroid swelling. Schimmer's test is normal. Vitals are stable. Coming to central nervous system examination, she conscious, oriented, right-handed. Higher mental functions are normal. MMSE is 28 out of 30. Cranial nerve examination is normal, including fundoscopy also. Motor system examinations, bulk is normal. Tone is decreased in the right foot and increased at other muscle groups. Grading of tone is according to modified Ashworth scale is 1. Coming to the power examination, in the upper limb, the power in bilateral shoulders muscle groups, in all movements it is normal, and elbow is also normal bilaterally. In at wrist, only ulnar flexion is weak, more on left side than right side. Left wrist ulnar flexion is 2 and right wrist ulnar flexion is 3. But the radial flexion is good bilaterally, and extension is also good at the wrist bilateral. Thus, power examination in the small muscles of the hand. Weakness of the hand muscles is more on the left than the right noted in. Abduction and adduction of the all fingers. Flexion of the distal phalanx of the left and ring finger and third and fourth limbricals. Format sign is present. All other muscles are relatively good. Power in the bilateral lower limbs. Bilateral hip, all muscle groups in all movements is 5 in flexion, extension, adduction, abduction, internal rotation, external rotation. In knee flexion extension, right knee flexion is weak than extension. It is 4 minus. Left is flexion extension are good. And the right ankle flexion, extension, dorsiflexion, plantar flexion, eversion, inversion, all are weak. Dorsiflexion is more weaker than the plantar flexion. In the left ankle, she has cellulitis and pain, and so she's not able to do up to the full power. In the right grade 2 and other toes, flexion and extensions are weak, along with adduction and abduction. Left side, the power is good in the toes. Coming to deep tendon reflexes, pectoral is present bilaterally. Biceps, triceps, supinator, and finger flexion, knee, all are brisk. And left side ankle clonus is present, 4+, and right side ankle absent. Superficial reflexes, corneal, conjunctival, pharyngeal, abdominal, and anal reflex are normal. Plantar reflex, right side not elicitable, left side is extensor. Going to sensory system examination, in the both left and right hand, she has decreased sensations and pain and temperature, along with hyperalgesias in both hands in this distribution. In the mainly on the little finger and half of the ring finger, along with the medial side of that dorsal aspect, palmar aspect, and also on the volar aspect also. And the bilateral hand is there, but more on the left side. The sensory distribution from the examination in the lower limb, right lower limb, is decreased on the sole of the foot, along with lateral leg and dorsum of the foot. The sensory examinations on the left lower limb is normal. Rhombox is positive. Vibration is decreased till anterior superior relaxed spine, and joint position is decreased at the bilateral grade 2. And gait is right high step-based gait. Cerebellum and extrapyramidal system, autonomic nervous system is normal. There is no neck stiffness, and Koenig sign is negative. SLR and Lessegue test are negative. Skull and spine are normal. There is no peripheral nerve thickening. Other system examination, cardiovascular, respiratory system are normal. There is no organomegaly in the parabdomen examination. Anatomical localization after examination. First, in the upper limb, she has weakness of the, we have to differentiate from the root, lower trunk, and middle cord and ulnar nerve. We have to confirm those suspected lesions from the history. So she has weakness of that interosseous muscles, and weakness of hypothenar and third and fourth lumbricals, weakness of distal finger flexion of the little and ring finger. And she also has sensory loss for the volar part of the medial hand and little finger and ring finger. Sensory loss on the dorsal medial and little finger. So the patient doesn't have any weakness of the thumb abduction and thumb flexion, because in case of C root or trunk middle cord, patient will have thumb abduction or thumb flexion weakness, but our patient didn't have any. So we will rule, we will exclude cord, trunk, and root involvement. In case of ulnar nerve at wrist and ulnar nerve at elbow involvement, because patient also has a distal flexion weakness of that little and ring finger, which is not seen in case of ulnar nerve lesion at ulnar nerve at wrist. And also dorsal medial part of the hand is involved. It is not seen in case of lesions at the wrist of the ulnar nerve. So our localization of the bilateral upper limb symptoms are mainly to the ulnar nerve at elbow, across the elbow. In case of right lower limb symptoms, we have to differentiate from root, plexus, and sciatic nerve, or common perineal nerve, or deep perineal nerve. The patient has weakness of both dorsiflexion and plantar flexion. And weakness of foot eversion is there, and inversion and knee flexion weakness is also there. From a patient has knee flexion weakness, it is not seen in a common peroneal weakness. So it is above the level of common peroneal. So sciatic or lumbar plexus or L5 root can cause knee flexion weakness. But there is no gluteal muscle weakness. So we will rule out lumbar plexus and root involvement. And also she has absent tendon reflex. Absent tendon reflex is not seen in common peroneal, but it can be seen when common peroneal nerve and posterior nerve are both involved combinedly. There is also decreased sensations over the web space and dorsum of foot and lateral calf, and sole of the foot is also involved. So from these weakness and sensory distribution, so we will localize and confirm that localization to the sciatic nerve, right sciatic nerve. So structures involved after the examination are bilateral ulnar nerve at across the elbow, left more than right sciatic nerve, and bilateral pyramidal tract involvement in the form of increased tone in all muscle groups except that right foot, and posterior column involvement in the form of rhomboxine positive and decreased vibration and decreased joint positions, and small or medium vessel involvement in the form of these cutaneous ulcers, which are more of looking like vasculitic ulcers. So after examination, the probable clinical diagnosis, mononeuritis multiplex with myelopathy plus vasculitis cutaneous ulcers. Yes,
Shall I start? நம்மளோட slide.
Thank you, Venkatesh, for presenting nicely and discussing the case clinically. I request Dr. Jasmine Kalyani to discuss further about the investigations and probable diagnosis. Dr. Jasmine Kalyani, please proceed.
Okay, sir. Thank you. Slide upload பண்ணு. Shall I start?
Go ahead, Dr. Kalyani, I'm listening.
Okay. Want to put my slides? Share.
Ma'am, you require any help?
Yeah, I want to share my slide. I want to share my screen with that.
Yeah. Venkatesh sir, can you unshare your screen, please?
Yeah, it is there.
Yeah, ma'am, you can share your slides.
Okay.
There is a green button of share screen below.
Okay, ma'am. Hello, everyone. I'm Dr. Jasmine Kalyani. I'm working as assistant professor in Tirunelveli Medical College. Thank you all for giving me this opportunity to present this case. I thank my chief and HOD sir, Dr. Saravanan, who guided us.
Madam, you are not audible. Speak loudly, kindly, please.
Okay. Volume raise. Can you hear me now? Is it okay?
Yes, ma'am.
Okay. I thank my chief and HOD, Dr. Saravanan sir, for guiding us to present this case. And I graduated from Tirunelveli Medical College. Right from my MD days, sir was my teacher. And now I'm working as assistant professor under in his unit. So, shall I proceed with the case? First, I'll brief about the purpose of presenting this case. This patient, 13-year-old female who presented with multiple individual nerve involvement, that is right ulnar and both ulnar and right sciatic nerve were involved, which suggestive of mononucleus multiplex. The patient also had spinal cord involvement in the form of increased tone in all four limbs, and the DTI was brisk and with a left ankle clonus and the extents are left plantar. Multiple vasculitic ulcers were seen in both lower limbs. The patient had excruciating pain. The probable diagnosis of myeloneuropathy, as what we discussed, that is with mononeuritis multiplex and myelopathy was made, and the etiology was probable of vascular etiology. The mononeuritis multiplex with myelopathy in vasculitis is very rare. Only few cases have been reported. So we proceed here in presenting this case. First, the investigations. First, the basic investigations were done. That is the CBC, that is hemoglobin was 14.5. The leukocyte count was increased, that is 21,200 was there. And the striking feature was that the eosinophil count was increased, that is 16%. And the absolute eosinophil count was 3,000 cell per cubic millimeter. So we proceeded with the peripheral smear, which also showed eosinophil leukocytosis. But she doesn't fit under the tropical eosinophilus syndrome, which I will detail in the next slide. So the other things were normal. The liver function test, the blood sugar levels were normal, the urea creatinine was normal, the serum electrolytes was normal, and then the urine protein was normal, urine creatinine was normal, the ESR was 35, and the phase reactance ERP was elevated, and the RA factor was negative, the CCP was negative, and the ANA was negative. And regarding the infections, we had seen for HIV, HBsAg, HCV, and COVID-19. But everything was negative. But recently we had the antibody titer results. We showed that it was raised, that is COVID antibodies were raised, that is 1 in 9, it was raised. And the neutral levels were normal, vitamin E was normal, and the blood and urine culture sensitivity was, there was no growth. And the slit skin smear for a Mycobacterium leprae, because Hansen's is very common in our country, so it was negative. The medial was negative. The AC levels were normal. Urinary protein, 20 urinary protein was normal. Urine microalbumin was normal. The bone marrow aspiration, the reports are awaited. The bone marrow aspiration was done to look for any eosinophilic infiltrates in the bone marrow. Then the CSF analysis was done, and the count was acellular, the protein was 25, and the glucose was normal, globulin was negative, the chloride was normal, ADA was only 4, and it is normal, and the gram stain and AFB stain were, showed no organism. And the CSF CBNAT Mycobacterium tuberculosis was not detected, because this young girl who was previously a known case of extrapulmonary tuberculosis, so we proceeded with the CBNAT also. Then next, regarding the conduction study, nerve conduction study, the amplitude was reduced in right ulnar, left ulnar, right tibial and common peroneal nerves. FAs are normal, and the snaps were not visible in ulnar and right scrotal and superficial peroneal, and the absent H reflex on the right side was noted, which all denotes an axonal neuropathy. MRI spine with brain staining was done, and it was normal. And the CT test, we were looking for any eosinophilic, any pulmonary infiltrates regarding this tropical eosinophilic syndrome. but there was no infiltrates and it was normal. And this is the COVID antibodies. They were elevated 9.12 IgG. And the ENA profile, we proceeded with the ENA profile, and the ENA profile was done in detail, and everything seems to be negative. See, all the antibodies were negative. And regarding the P-ANCA, C-ANCA also, everything was negative. And the nerve muscle biopsy of superficial peroneal nerve with the peroneal previous muscle was done, and the reports are awaited. So, with this investigations, we have come to a conclusion that she doesn't belong to any systemic vasculitis. It is a NSV. We are that the probable diagnosis is made based on the available investigations report and the clinical examination and the conduction study reports. So, I'm going to brief about the non-systemic vascular neuropathy. So, there is a classification criteria by the Peripheral Nerve Society. The consensus definition, they are given it as a definite, but our case fits in for the probable NSV. So, regarding the NSV definite, everything comes regarding the histopathological examination, but our biopsy reports are still pending. So, I'm proceeding with the next slide. That is probable NSVN. Our case fits in for this diagnosis. A case, this probable vasculitic neuropathy, the patient will have the sensory or sensory motor environment, and the patient will have asymmetric or multifocal pattern. Here we have both ulnar and it is a multifocal also, because common nerve is also involved, and the lower limb predominance is there, distal predominance is there, pain is there, and non-demyelinating electrodiagnostic features are also there. So, regarding the NSVN, our patient fulfills all the, say, out of the 6 criteria are fulfilled for our patient. So, regarding this NSVN, I'm again briefing. It is an axonal neuropathy, progressive, distal predominant, asymmetric, multifocal, associated with the disabling paresis. So, we are going to see more about this NSVN. The subtypes, there are many subtypes. There is Wartenberg migratory sensory neuropathy, surgical inflammatory neuropathy. There are diabetic related, 2 types, non-diabetic related, and localized to cutaneous and neuropathic vasculitis. Our patient comes under this. In NSVN, our patient comes under this subtype, that is localized to cutaneous vasculitis. That is the skin nerve vasculitis overlap with NSVN. So the skin nerve vasculitis, the patient has got cutaneous manifestations in the form of multiple painful ulcers, and the patient has a neuropathy also. So the skin nerve vasculitis overlap with NSVN. This is the final diagnosis. We have arrived with this investigations and the clinical presentation. So she has eosinophilia. So we just try to fit in her for this hypereosinophilic syndrome, but finally she doesn't fit in for that. But because these are the things that should be fulfilled for that hypereosinophilic syndrome. Because in hypereosinophilic syndrome, the patient will be having mononeuritis multiplex. Here the provisional diagnosis of mononeuritis multiplex is arrived, and so we are deriving the etiology based on that. So this hypereosinophilia, the absolute eosinophil count is more than 1,500 cells, and then it should be checked for more than 2 occasions. Evidence of eosinophil mediated target organ damage is not present in our case. In future, she may develop, and then exclusion of other potential causes of eosinophilia. And alternatively, the tissue hypereosinophilia can be identified in addition to an elevated absolute eosinophil count with tissue hypereosinophilia. How is it defined? Means the eosinophils, more than 20% of the nucleated cells in the bone marrow. So this bone marrow will change the diagnosis, bone marrow examination. Then extensive tissue infiltration of target organ by histologic analysis. So this target organ histology also is pending in our case. So these things cannot be fitted in for her. So this regarding histologic evidence of eosinophilic degranulation in target tissue, the absence of eosinophils in the target tissue. So the eosinophilic degranulation also cannot be demonstrated. So this diagnosis, that is hypereosinophilic syndrome, except for the eosinophil count which is raised, and she has an eosinophilic leukocytosis also in the peripheral smear. Probably this 13-year-old girl, she may be too young for the full manifestations of the disease. She may later on manifest with the markers. She may later on manifest with these infiltrates. She may later on manifest with this target organ damage, etc. So at this point, we cannot fit in her for this hypereosinophilic syndrome. So it is ruled out at this point. Next, coming to this vasculitis, we are arriving this anyway, we are arriving at the diagnosis of a vasculitic neuropathy. So regarding this systemic vasculitis, we have ruled out the possibilities of systemic vasculitis, but here I'm briefing about the vasculitis for the sake of the residents. So this vasculitis of the small vessel, medium vessel, and large vessel. So see, this is vasculitis of the medium-sized vessels. It is Panatartis nodosa and Kawasaki disease. And here, small vessel vasculitis, Henoch-Schönlein purpura, cryoglobulinemia, hypercomplementing ureteric vasculitis, ANCA-associated vasculitis, that is granulomatous with polyangiitis, eosinophilic granulomatous with polyangiitis, microscopic polyangiitis. So this is regarding the vasculitis. And this is about the vasculitic neuropathy. So how this vasculitic neuropathy occurs in the case of vasculitis. So the vasculitis is a systemic illness with the inflammation in the blood vessels. So the inflammation, what it does, the inflammation may lead to occlusion of the blood vessels and subsequent ischemia in the organs and tissues. When the inflammation is in the vasa nerva, mainly the epineurial arteries of the nerve, leading to thrombosis and ischemic damage, the patient may develop vasculitic neuropathy. This young girl with the peculiarity, she has come to us with the neuropathic features as an initial presentation. So this patient is presented with the vasculitic neuropathy to us, not with any systemic signs of vasculitis. So this diagnosis of vasculitis, so here I am briefing about the vasculitic neuropathy. So this diagnosis of vasculitic neuropathy is based on the history, clinical examination, and supporting lab investigations. So these include the nerve conduction studies, biopsies, and then nerve and muscle biopsy for histopathological examination. And this is regarding the vasculitic neuropathy. So how does it present? First of all, that is mononeuritis, multiple mononeuropathies, usually painful, and then overlapping mononeuritis multiplex. And the third is the generalist symmetric polyneuropathy. Our patient has multiple overlapping mononeuritis multiplex and also a symmetric polyneuropathy also she has. So this is about the presentation of the vasculitic neuropathy. So there are two types of mononeuritis multiplex pattern. There is simple and overlap forms. Actually, they are more common. This is 60 to 70%. They have mononeuritis multiplex, this vasculitic neuropathy. And polyneuropathy is present only in 30 to 40% of these cases. So these are the various presentations of the vasculitic neuropathy. So regarding the systemic constitutional symptoms, our patient did not have any systemic or constitutional symptoms. So this duration of the neuropathic symptoms was also quite very short. And then initial neuropathic symptoms, sensory. Our patient presented with the sensory symptoms, that is paresthesias. And also she initially paresthesias, and later on she had both sensory motor also, that is paresthesias and weakness, and then motor. The onset of the neuropathic symptom, upper limb and lower limb. Our patient had lower limb symptoms predominating. And then clinical pattern of the neuropathy, our patient had mononeuritis multiplex and diffuse polyneuropathy mononucleus multiplex. Sensory and sensory motor neuropathy. Our patient had both sensory motor neuropathy, and clinical course is subacute. And regarding this mononucleus multiplex, everybody will be knowing, but for the sake of residence, I'm just revising it. It is a painful, asymmetric, asynchronous, sensory or motor peripheral neuropathy involving simultaneous or sequential damage to two or more non-contiguous peripheral nerves. So these are the causes. Already our resident had put it as a differential diagnosis, but again I'm just revising it. So regarding the infections, Lyme's disease, leprosy, hepatitis A, B, C, parvovirus, herpes simplex, HIV. So we have done our best to rule out the common investigations, the common infections, that is leprosy, hepatitis A, B, and C, and HSV and HIV. And we had also investigated for COVID-19, and the patient had a raised antibody titer. And regarding the rheumatological disorders for regions, National Lymphatic, Sjogren's, Behçet's, temporal giant cell arteritis. So detailed ENA profile was done to rule out these disorders, especially rheumatoid arthritis, polyarteritis nodosa, and scleroderma. And we had ruled out all these disorders. So some of the chronic diseases also can be associated with that. So the diabetes, amyloidosis, neurosarcoidosis, and celiac disease. Our patient did not have any other chronic diseases like this. She didn't have any predisposing illness or chronic disorders. And malignancy. So malignancy was also ruled out in our patient. So the malignancy can be associated with the mononucleus multiplex. And mononucleus multiplex can be associated with the chronic graft versus host disease, or due to the direct tumor invasion with the interneurospectatus lymphoma, leukemia, carcinoid tumor. And regarding this paraneoplastic also, the small cell lung cancer, this mononucleus multiplex can be associated. Only for this, we had done the CT chest to rule out everything. So this hematological disorders. So this mononucleus multiplex can be associated with the following hematological conditions: Chostras, eosinophilia, cryoglobulinemia, atopy related to neuritis, ITP. So regarding this hypereosinophilia, a patient has a eosinophil count, increased eosinophil count and eosinophilic leukocytosis. Other than that, she doesn't fit in for the criteria for the hypereosinophilia syndrome. Maybe she may be manifesting with other findings later on. She may or may not. So regarding this vasculating neuropathy, again, it is divided into a systemic and a non-systemic. So we have done our best to rule out the systemic illnesses, all the systemic illnesses. This is primary, that is polyarteritis nodosa, ANCA-associated vasculitis, cryoglobulinemia. Secondary to connective tissue disorders, sarcoidosis, infection, drugs, and malignancy. And then non-systemic, recurrent, chronic, and self-limiting. So this non-systemic vascular neuropathy, the skin nerve vasculitis. So we are fitting our patient under this category. And then Wattenberg migratory sensory neuritis. So diabetic and non-diabetic inflammatory plexopathy, post-surgical inflammatory neuropathy. So the ESR, CRP, and RA factor elevated in vascular neuropathy. So Church-Strauss syndrome, evaluation, the CSS is Church-Strauss syndrome. Evaluation is remarkable for eosinophilia and ANCA, but here eosinophilia is there, but ANCA is negative. Primarily MPO or P-ANCA, because of the perinuclear staining pattern, it will be seen. So in 2/3 of the patients, at least, this will be present regarding Church-Strauss syndrome. So initially, we kept in our mind regarding the CSS also, this Church-Strauss syndrome, because of the eosinophilia she had. During the day 1, the CBC was done, and she showed increased eosinophilic count. And regarding this pan, they are associated with hepatitis B, C, HIV. So all these investigations were done, and she was negative. And In the next for the C-ANCA was done to rule out GAN. For regarding MPA also, P-ANCA was done and it was ruled out. So biopsy was confirmative, but unfortunately we haven't received the pathology reports. Biopsy is pending, so we cannot conclude with the definite diagnosis. So we prefer to biopsy the superficial peroneal nerve because the peroneal muscle can also be biopsied at the same time. The nerve muscle biopsy. So the diagnostic yield is increased when the nerve and muscle are both are biopsied. So the definitive histological diagnosis of the vasculitis requires transmural inflammatory cell infiltration and necrosis of the vessel wall. So this is the definitive histological diagnosis of the vasculitis. But here in our case, we lack this because of the pending biopsy reports. So this is about the CNS involvement and the other system involvement regarding the vasculitis. In PAN, we have CNS and CNS involvement on 5%, and the other systems are also involved, like skin joints. In microscopic polyangiitis, this renal manifestation will be more common, and the CNS involvement is 10 to 15%. But here we are talking only about the myelopathy, not any CNS involvement. Our patient doesn't have any CNS symptoms. Both symptomatology and then also an examination and investigations also rule out the CNS involvement. Only myelopathy is there. Then eosinophilic granulomatosis, the increased eosinophils will be there. The lungs will be involved in 100%. But here she doesn't have any lung involvement. The granulomatosis with polyangiitis, the ENT involvement will be more common, and the PNS and the cranial nerves will be involved. In IgA vasculitis, this skin will be more involved. Here also skin is involved, and the next joints are involved. She doesn't have any joint involvement. GIT involvement also she doesn't have anything. Next, cryoglobulinemia. They will have the skin, joints, and salivary glands, Raynaud's membrane, which she doesn't have anything. Giant cell arteritis. Here, increased ERP will be there, increased CSR will be there. The patient will have a different presentation. And then regarding non-systemic vasculitic neuropathy, our patient fits in for the non-systemic vasculitic neuropathy. So,
Ma'am, sorry to disturb you. Ma'am, your voice needs to a little bit increase, ma'am. It's not coming, it's coming slowly, ma'am.
Okay, ma'am.
Yeah, now it is coming fine.
Okay, now can you hear me?
Yes, ma'am. Yes, ma'am.
Okay. So the main stage of the initial treatment systemic vasculitis is a combination of corticosteroids. We are tried with corticosteroids. And the next step is the cyclophosphamide, and she is responding well to corticosteroids. So in severe vasculitis, we have to start with the first methylprednisolone, that is 1 gram QD for 3 days, and then we have to switch on to oral prednisolone, 1.5 milligram per kg per day. After 2 weeks of alternate day prednisolone, bisphosphonates should be given to reduce the steroid-induced osteoporosis. The cyclophosphamide is started at the same time as corticosteroids and can be given orally or IV pulses. Oral is 1 to 2 milligram per kg per day. We prefer monthly IV pulses of cyclophosphamide, that is 500 to 1000 milligram per meter square. And sodium mercaptopurine sulfonate, mesna should be given to. We all know that it is toxic to the bladder. So hemorrhagic cystitis will occur. No, so we are giving mesna. So we have to continue this high dose corticosteroids and cyclophosphamide treatment till the patient improves or stabilizes within 3 to 6 months. Then we can discontinue the cyclophosphamide and replace with azathioprine.
Dr. Jasmine, talk a little louder, ma.
Okay. Volume raise பண்ணனும் கலா. கலா volume raise பண்ணனும். கேட்கல. Can you it's minus plus.
Yes, talk now. Madam, talk louder.
Now can you hear me, sir?
No.
No.
Ma'am, if it is okay, you can remove your earphones and then you can speak. You can try to check that. If
Okay. Can
yeah.
you hear me now? Can you hear me now?
Your voice is very feeble. Can you
Now can you
directly
hear me,
talk
sir?
to the? Can you directly talk without the earphone?
Okay. Okay.
Remove its connection, madam, from the computer and speak directly without any earphone. Don't, madam, please don't use any earphone and unplug it from the computer.
Okay, sir. Now can you hear me, sir?
Speak as loudly as possible.
Bluetooth open.
Yeah, talk, madam. Talk.
Okay,
Please
sir.
talk.
Can you hear me now?
Yeah. Now talk.
Slide.
Yes, continue.
Slide.
Eddie, can you help them?
Yeah, sir. She's ma'am. You need to go full screen.
No. Yes, madam. Can you hear me now? Okay.
Yeah,
Yes,
Yes,
ma'am.
now the voice is very clear.
It
Please
is very
continue.
clear. Yeah. Please continue, ma'am.
Okay. So the patient should be put on corticosteroids and cyclophosphamide, and subsequently we can discontinue the cyclophosphamide and replace with the azothioprine or methotrexate. And the patient with CSS, they can be continued with low doses of prednisolone. And there is rituximab is very effective drug, that is 375 milligram per meter square per week for 4 weeks. It can be used to induce remission in ANCA-associated vasculitis, and other immunosuppressive agents may be used for the treatment of vasculitis, but it is less well documented. Methotrexate up to 25 milligram per week can be used. Mycophenolate mofetil 1000 to 1500 milligram twice daily is used. Azothioprine, cyclophosphamide, cyclosporin, tacrolimus, IVIG has been tried in refractory cases. So conclusion, only very few cases have been reported that is regarding this myeloneuropathy in vasculitis. That is acute myeloneuropathy, an uncommon case presentation of Sjogren's syndrome by Rajesh Sharma in Annals of Indian Academy of Neurology. Myeloneuropathy in a case of Hashimoto's Kyle. So our case fits in for this rarity. Regarding this take-home message and conclusion, our chief will brief you about this. Because our patient has presented with a neuropathy as the first manifestation of vasculitis, and this even earlier, the extensive diagnostic pathway is necessary to confirm or exclude the diagnosis of vasculitis, and so high index of suspicion is needed to make this diagnosis based on the clinical features. So thank you all for giving me this opportunity, and our chief will conclude this. Choti sir, Saravanan sir will take over now. Thank you, sir. Thank you.
Thank you, Jasmine madam, for your elaborate and nice presentation. Am I audible, sir?
Yes.
Yes, sir.
Yes, sir. So, when the case came to us, we were able to make a diagnosis of mononeuritis multiplex first. And we were thinking of it is a vascular neuropathy. We used to get mononeuritis multiplex cases on and off. And a few cases we approved as vascular neuropathy by doing biopsy, etc. Biopsy procedure will take some more time for us, and we are in the process. But what was surprising for us was that we had upper motor neuron signs during examination. We had upper motor neuron signs, and very surprised to get an ankle reflex in what is ankle chronus. In one foot, where the other foot, the ankle reflex was absent, and the one foot, the ankle, the plantar reflex was extensor, and the other one plantar was absent. So we are very much surprised that there is involvement of the cord along with the peripheral nerve. Peripheral nerve is not in a symmetrical person as getting accumulating neuropathies in cases of acute disseminated stomatitis or myeloneuropathy, etc. Here it is a myelopathy along with the mononeurase multiplex pattern, which is suggestive vasculitis. And the ulcers over the skin which are present were also suggestive vasculitic ulcers which are not healing with antibiotics. So we were investigating the case to find out what is the cause of this one. And we have seen few cases like that because of collagen vascular diseases like SLE. Because these collagen vascular diseases, even if you have done a ANA profile and ANA profile, etc., which are absent at this point of time, if you follow these patients over a course of time, some of these markers may develop at a later time. That's what Jasmine was telling. Even though this is considered as a case of non-systemic vasculitic neuropathy, this will later turn out to be a systemic vascular neuropathy because the markers, the dsDNA, SM, anti-SM, anti-RO, these antibodies may be present later. That is, they are not present at a particular point of the time. They will evolve over a period of time. That is what is discussed with regard to collagen disease, connective tissue disorders. But at this point of time, we do not have any points to say that this is a collagen disease. This is a disease which is presented with a vasculitic mononeuritis multiplex, which has picked up the this spinal cord also in the form of myelopathy involved in the long tracts, mainly the pyramidal and posterior column. And of late only we got 2 days back only we got the antibody titer for the COVID, which was positive, highly positive 9. And we do not know whether this is because of a post-infective demyelinating vasculitic neuropathy, because of a corona infection itself. We do not know because such cases are not described in literature. So we thought this is a what case to present in this forum which contains a elite audience and learned persons. I request our senior professor, Dr. Sudhir, and our guide, Dr. Lakshmi Narasimhan, to share their experiences and give their views about this case. Thank you, sir.
Lakshmi, would you like to take over? Dr. Lakshmi, please go ahead. Hello. Dr. Lakshmi Narasimhan. Anyway, I must compliment Dr. Saravanan, Dr. Jasmine, and the team for this wonderful case. It's a great learning. It is not simply mononeuritis multiplex, it is myeloneuropathy. Yeah, so it's certainly a rare combination, and as we were trying to demonstrate, this looks non-systemic vasculitis at times with eosinophilia. While waiting for the reports of bone marrow and nerve and muscle biopsy with histopathology, I think the discussion was very lively and thorough, and I think it gives overall complete consideration of all differential diagnosis for us to learn neurology in a very eloquent manner. So I do agree that this could be Sjogren or some other eosinophilic related syndromes. And unless we have biopsy reports, I think it is very difficult to conclude. But I think the discussion leads us to this direction. Dr. Lakshmi, would you please like to?
Yes, sir. Yes, sir. There are a few questions. Sir, how explain axonal pathology without significant wasting? Question by Dr. D.K. Nagar.
So how to explain axonal pathology without wasting?
Yes, sir.
So these diseases started very acutely. So we identified the disease and we treated the disease immediately.
Pretty early in the course of the disease. Okay.
So we did not allow time for the muscle to atrophy.
Yes, sir. Okay, fine. The next question was leprosy considered in the differential diagnosis?
Yes, sir. We took opinion from the dermatologist. The dermatologist ruled leprosy by taking that slit skin smear, which usually they take in seven places. All of them were negative. Leprosy was considered in the diagnosis, and the dermatologist excluded leprosy in this case.
This question from Dr. Surendra Kumar, and Dr. Thomas has asked NSV and will it cause myelopathy, non-systemic vasculitic neuropathy?
So the myelopathy is the one which we are discussing here. That is the one which is highlighted because all the systemic vasculitis, non-systemic vasculitis involved in the central nervous system. That is very rare. The central nervous system, what Jasmine was telling was involved into the brain. There is a cranial nerves, seizures, etc. If you go to the literature of any collagen vascular diseases involving this causing this vasculitic neuropathy, if they involve the central nervous system, the most common manifestation is a seizure. And after seizures, the second most common manifestation is the behavioral and psychiatric problems. And some of the patients will present with focal neurologic deficit in the form of chemotherapy. Patients presenting with the myelopathy in a case of systemic vasculitis and non-systemic vasculitis is very, very rare.
Rarity, yes. Very, very rare. Okay. These were the three questions, sir. And I really wanted to congratulate for an excellent presentation by your postgraduate. And his analysis were really made us enjoy. Dr. Jasmine she's added one more glory to your feather by discussing the case beautifully, the investigations and all, and approach. And it was really an intellectual feast. And I really thank the Tirunelveli Medical College for having accepted our kind invitation. And this discussion really lingers in our mind for quite a long time. And thanks for showing such a rare case. Sir, I just wanted to, sir, with the approval, sir, next time is Christmas, sir. So Dr. Shankar from Ramachandra Medical College, he requested whether they can do it in the first week of Jan. That is 7th of Jan, sir. Because everybody would be interested in the New Year, sir. If you permit, I'll. Sir?
Dr. Lakshmi, just for discussion, sir, is it possible to prepone by a week in that case to keep December, because otherwise we'll be skipping one.
No, so we are not skipping, sir. The December 1 is on the Christmas Eve, the other is on the New Year Eve, sir, both the Fridays. The one Friday before that is TANCON, sir, Tamil Nadu Association of Neurologists.
No, I'm not saying that. I'm saying
No,
instead of Friday, can we prepone it to Thursday or Wednesday and keep on Thursday?
Prior to Christmas, I'll finalize it, sir. Anyhow, the college, I'll finalize the date and let you know. The college would be Sri Ramachandra Medical College and Higher Institution Research. Professor Shankar will take over.
Wonderful.
We'll confirm the date and then let you know, sir. Any change in the date?
Wonderful, wonderful.
Thank you.
I have no other objection, but just to, keep...
ensure that it happens in December. Sure, sir.
Sure. Otherwise, I'm fine. Then we'll do 2 programs in January. Otherwise, no issue.
Yes, sir. Yes, sir. Thank you, sir.
Thank you. You may conclude, Dr. Lakshmi.
Yes, sir. My sincere thanks to Mr. Venkatesh. Thanks to Professor Dr. Jasmine and Professor Saravanan, and such a short notice, extraordinary case. Thank you. And thanks to all the delegates who have gathered to attend this case. And my sincere thanks to Professor Sudhir Shah, whose inspiration keeps us almost, we are nearing our silver jubilee. So I would be delighted to celebrate that. And meanwhile, I also thank the Intas Pharmaceuticals, the Arun Chadda and his entire team. I thank Eddie for doing a coordination job in an excellent manner all throughout this program. Over to Professor Arun Chadda for any other remarks. Thank you.
Thank you. Thank you very much, sir. And today it's really great day that we are at the end of 17th session of Secret of Neurology web series. The entire 17th session turned out to be very successful, and I would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 17 months. It's audience like you that makes the presentation awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to thank our Honorable Course Director, Honorable Dr. Sudhir Shah sir and Honorable Dr. Lakshmi Narasimhan sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DND students. And I would like to thank our young neurologist, Dr. S. Venkatesh, for presenting the excellent and unique case. Further to this, I would like to thank Jasmine ma'am for presenting a case and investigation and discussion, and Dr. Saravanan sir, the HOD Neurology Department, Tirunelveli Medical College, Tirunelveli, for providing the important learning points, the proceeding of this unique case and expert comments. And the entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's being a pleasure being with all of you. Thank you all for your patience, and I wish you all a very good night now, with a promise that next month we will meet again with yet another, awaiting the next session of Secret of Neurology. Till then, stay safe and take care. Thank you. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Oh, thank you. Good night to everyone.
Thank you,
Thank
ma'am.
you. Thank you very much, sir. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Thank you.